Welcome to this deep dive. If you're a resident preparing for the FRCS board exams, you are exactly where you need to be.
Right.
Our mission today is a high-yield, direct review of the clinical management of open lower limb fractures. We are here to help you completely crush those boards.
So you need to focus up because we're getting right into the heavy-hitting material today.
Absolutely. But really quickly, press follow on whatever platform you're using right now so you never miss these deep dives. And if you learned something valuable today, rate the show. Oh, and you definitely need to get a premium subscription.
Yeah, that's the absolute only way you'll be able to listen to the Journal Club and Clinical Cases deep dives.
Exactly. All right, no more delays. Let's dive straight in. We're starting with the foundation, epidemiology. What is the baseline data and the typical patient profile for open lower limb fractures?
Well, you really do need to know these numbers cold for the exams. The annual incidence sits right at about 5 per 100,000 population.
Okay, and the demographics?
The average age is 42. And if you break down the mechanism of injury, the three most common culprits you're going to see are falls from a height, motor vehicle collisions, and interpersonal violence.
Right. And it's also crucial for you to know how those injuries break down by type based on the classical data.
Yeah, those percentages are heavily tested. You've got 21% sitting in the Gustilo type I category, 19% are Gustilo type 2, and then you have this massive chunk.
60%.
Exactly, 60% are Gustilo type 3. And examiners love to dig into that specific category.
Because it's so severe.
Right. And within that 60%, type IB makes up another huge majority at 60% of those injuries.
Yeah.
Type I FIDE accounts for 27%, and type IA makes up the final 8%.
Which brings us to the classifications themselves. If you look at the literature, we have so many systems out there.
Too many, honestly.
Right. You'll read about the Hanover classification, Burton-Spicer, the AO soft tissue grading system, NISA, the Ganga hospital score, and even the Bastion classification for military IEDs. But for the exams, you have to know the Gustilo and Anderson system.
You can't escape it. But it is incredibly important to understand why you can't escape it and why it's actually deeply flawed.
Let's break those pitfalls down.
It's widely used because it's simple to apply on the fly. But the biggest trap you can fall into as a resident is treating the Gustilo score as an objective, flawless metric. First off, it's based on a retrospective study of long bone fractures, which immediately limits its predictive power.
Right.
Second, and this is a major clinical pitfall, it has incredibly poor inter-observer reliability.
Meaning what you call a IEA, your attending might call a AIB.
Precisely. It's highly subjective between observers. Third, it completely ignores specific fracture characteristics or underlying nerve and muscle injuries.
Which makes grade third be this massively diverse catch-all group.
Exactly. Those injuries do not all behave the same way, and they don't require the exact same reconstruction. And finally, the most crucial exam point here. Open fractures are best classified only after wound excision.
That is a massive point to underline. Applying a Gustilo grade in the trauma bay before you've even done a surgical debridement is a classic clinical error.
It absolutely is. You cannot accurately grade what you haven't fully explored.
Let's run through the rapid-fire breakdown of the Gustilo classification exactly as you need to recite it when the examiner asks.
Sure. Type I is your clean open fracture with a wound less than 1 centimeter long. Type 2 is a laceration greater than 1 centimeter, but crucially, it doesn't have extensive soft tissue damage, flaps, or avulsions.
And then type 3 is where it gets heavy.
Right. This is either an open segmental fracture, an open fracture with extensive soft tissue damage, or a traumatic amputation. But here is the trick that candidates frequently overlook. All high-energy pattern injuries are automatically type 3.
Irrespective of the wound size.
Exactly. Don't let a small puncture wound fool you.
So that includes things like farm injuries because of the massive contamination risk, any gunshot wounds, or injuries needing vascular repair.
Spot on. Now, Gustilo subclassified type 3, and you need to know these intimately. Type 333 means you still have adequate soft tissue coverage of a fractured bone, despite extensive soft tissue laceration or flaps.
The bone can be covered.
Right. Whereas type IB involves extensive soft tissue injury with periosteal stripping and bony exposure. You just don't have the local tissue to cover it.
Yeah.
And it's almost always associated with massive contamination.
And type IS is the easiest one to remember.
Any open fracture associated with an arterial injury requiring repair.
Perfect. Now, once you've classified the injury, you have to make objective decisions about limb salvage versus primary amputation. This is where the MSS comes into play.
The Mangled Extremity Severity Score. It's designed to predict whether a lower limb is actually salvageable and breaks down into 4 objective categories.
Let's go through them. First is skeletal and soft tissue injury.
Right, this scores from a 1 for a low-energy injury, like a simple fracture or a stab wound, all the way up to a 4 for very high-energy trauma with gross contamination and soft tissue avulsion.
The second category is limb ischemia.
This scores from 1 for a reduced pulse with normal perfusion up to 3 for a cool, paralyzed, completely insensate limb. But here is the critical exam caveat you must state.
You have to double the score if the ischemia has been present for greater than 6 hours.
Exactly. That time factor is totally devastating to the tissues.
The third category is shock.
You score a 0 for stable blood pressure over 90, up to a 2 for persistent hypotension. It's all about systemic perfusion.
And finally, age.
Points increase as the patient gets older. It's a 0 if they're under 30, 1 point for 30 to 50, and 2 points for over 50 years of age.
So when you tally that all up, what's the threshold?
A total score of 6 or less suggests a salvageable limb using modern reconstructive techniques. But, and you must explicitly state this to your examiner, a scoring system never replaces experienced clinical judgment.
It's a tool, not a mandate.
Exactly.
And just to round out the scoring discussion, you should briefly mention the NISA score. It's an alternative specifically for open tibial fractures. It factors in nerve injury, making it more sensitive and specific than the MSS.
Okay, let's shift gears. The patient has been classified, scored, and now they're rolling through the doors into your trauma bay. What is the immediate approach?
You're starting with the ATLS-style primary survey,
Right, but you also need to mention the military approach, the CABC algorithm.
where that C stands for catastrophic hemorrhage.
You treat that first, right out of the gate. In an exam setting, explicitly state that a tourniquet may be required immediately to stop the bleeding before you even think about the airway.
Once they are stable and you're doing your clinical exam, what are the specific physical flags that scream high-energy injury?
Well, the mechanism is your first massive clue. But physically, look for transverse or segmental fracture patterns with combination. Look for large, soft tissue defects, and literally look for tire prints on the skin.
And closed degloving. That's a huge one because it's so deceptive.
But a classic trap. The skin looks completely intact from the outside, but the shearing force of the impact has completely ripped off the underlying perforating vessel.
The skin is dead. It just doesn't know it yet.
Exactly. Now, for the neurovascular exam, precision is everything.
You check the capillary refill time, but you cannot rely on it as your sole metric. It will lie to you.
You have to physically palpate the dorsalis pedis and posterior tibial arterial pulses. Check active movement of the toes and ankle to test the common peroneal and tibial nerves.
And for sensation, you have to be specific.
Test the sole of the foot for the tibial nerve and check the first web space for the deep peroneal nerve. And remember, you must re-examine the neurovascular status constantly, especially after any fracture manipulation.
Which brings us to the UK standards for immediate initial treatment in the emergency department. These are heavily tested.
Step 1 is analgesia. Step 2, restore limb alignment and split it using a plaster of Paris back slab.
Step 3, photograph the wound.
Right, so every single consulting team doesn't have to keep taking down the dressing and exposing it to more bacteria.
Step 4, cover that wound with sterile saline moistened gauze and a semi-occlusive film dressing.
Step 5, repeat your neurovascular exam. Step 6 is intravenous antibiotics. You want to give coamoxiclav early, within the first hours, and continue it until definitive soft tissue cover.
Then, at the time of surgical debridement, you add a single shot of gentamicin at 1.5 milligrams per kilogram.
Step 7 is administering tetanus prophylaxis if required. And Step 8, obtain x-rays. You need 2 views, and you absolutely must include the joints above and below the fracture.
All right, let's move out of the trauma bay and into the operating theater. Primary surgery, debridement, and assessment. Let's talk timing. Is the traditional 6-hour rule still the gold standard?
It isn't. The 6-hour rule is completely historical.
It was originally based on the doubling time of Staphylococcus, right?
Yeah, the time it takes one bacterium to reach an infective load of 10 to the 5th organisms. But subsequent studies completely failed to prove a strict relationship between that rigid 6-hour window and actual clinical outcomes.
So what are the current UK standards?
They recommend primary surgery within 24 hours of injury by senior plastic and orthopedic surgeons for low-energy trauma. For high-energy trauma, you need to be in theater within 12 hours.
The only times immediate surgery is indicated are for four specific scenarios: gross contamination, compartment syndrome, a devascularized limb, or if the patient has another associated injury that requires immediate life-saving surgery.
Now, the major goal of this primary surgery is to convert a contaminated traumatic wound into a clean surgical wound. We do this using the 3 E's.
Extend, explore, and excise.
When you extend, you do it along the lines of election for fasciotomy so you can assess the entire zone of trauma.
Yeah.
But you have to be incredibly meticulous not to injure the perforators that supply your local fasciocutaneous flaps.
Let's talk about degloving, since we brought it up earlier. It's the avulsion of skin and subcutaneous tissue from the underlying muscle or bone.
We classify this using the Arnish classification. And the easiest way for you to picture this is to imagine the muscle fascia is a wall.
Okay.
Pattern 1 is limited degloving. It's mostly just abrasion or avulsion around bony prominences. Pattern 2 is non-circumferential degloving, where most of the skin remains as a flap superficial to that fascia wall.
But pattern 3 is where it gets circumferential.
Right, circumferential single-plane degloving. This strips the skin right off that wall entirely around the limb, and the skin usually does not survive.
And pattern 4 is the really devastating one.
Circumferential multiplane degloving. It is so high energy that it actually breaks through the wall. The degloving runs between the muscles and even between the muscle and the periosteum. It indicates massive energy transfer.
Assessing skin viability in those degloving injuries can be tough.
You look for fixed staining and thrombosis of the subcutaneous veins. You can also use intravenous fluorescein and a Woods lamp, or newer technologies utilizing indocyanine green or ICG fluorescence to objectively map out perfusion.
For tibial injury specifically, you must reference the Duncan classification. It dictates exactly how you manage the soft tissues.
Type I are clean lacerations. You manage those simply with Steri-strips. Type 2 involve minimal hematoma or skin edge necrosis. You debride the non-viable tissue, evacuate the hematoma, and close with Steri-strips without tension.
Type 3 involve moderate to severe hematoma or necrosis. That requires formal debridement and a split skin graft.
And type 4 is a major degloving injury. That requires complete debridement and major reconstruction, and it must be done under a general anesthetic.
Once you're inside the leg, you have to objectively assess muscle and bone viability. For muscle, it relies entirely on the 4 Cs.
First is color, which should be a healthy pink. Second is contraction when stimulated. Third is consistency. And the way to remember this is that dead muscle turns to mush. It tears easily in the jaws of your forceps. Fourth is the capacity to bleed.
For the bone, you actually deliver the ends of the fracture out of the wound so you can inspect the deep posterior compartment. You perform the tug test with your forceps.
If a loose bone fragment fails the tug test and pulls right out, it gets removed. But be careful, you must preserve large, absolute stability articular pieces.
Bone viability itself is determined by looking at the extent of periosteal stripping and checking for the paprika sign.
That's punctate, pinpoint bleeding from the exposed cortical surfaces. If it looks like sprinkled paprika, it's alive. Following excision, you irrigate the wound with massive volumes of warm saline.
And here is a huge exam trap. You must explicitly state that high-pressure pulse lavage is never recommended.
It doesn't just clean the wound. It acts like a pressure washer, driving bacteria deeper into the tissues and causing severe mechanical damage.
Exactly. Now, let's talk vascular injuries and skeletal stabilization. What is the precise protocol if the patient rolls in and you've got absence pulses?
A devascularized limb is a true surgical emergency. Muscle suffers irreversible ischemic damage in just 3 to 4 hours. 6 hours is the absolute maximum acceptable delay of warm ischemia time.
You diagnose this by absent dorsalis pedis or posterior tibial pulses on palpation or with a Doppler.
And as we said earlier, capillary refill in the toes is highly misleading. Do not trust it for this diagnosis. Crucially, do not order preoperative angiography.
It's a waste of time.
It unnecessarily prolongs the ischemia. The level of the vascular injury is already reliably predicted by the level of the fracture or dislocation.
The surgical sequence for revascularization is strict. First, direct exploration of the suspected site of injury. Second, immediate revascularization utilizing temporary shunts, like a Javid, Pruitt-Inahara, or Sundit shunt.
And note that even venous injuries at or proximal to the popliteal vein get shunted.
During this phase, you have to talk to your anesthetist because you must be prepared for severe cardiovascular events.
As soon as you open up that flow, Toxic metabolites from the ischemic limb wash into the systemic circulation. You also must employ renoprotective measures to prevent the kidneys from shutting down due to myoglobinuria.
Third, once circulation is restored, you reassess the limb. Fourth, if it's salvageable, you stabilize the skeleton with an external fixator. Fifth, you replace those temporary shunts with reversed vein grafts.
Finally, and do not forget this in your exam, a fasciotomy is strictly required following revascularization.
Yes, the muscle is going to rapidly swell postoperatively due to reperfusion injury.
If you don't release those compartments, you'll lose the leg you just saved.
Let's touch on the rules regarding provisional versus definitive skeletal stabilization. Provisional stabilization is achieved with a spanning external fixator.
You use this when definitive stabilization and soft tissue cover just cannot be achieved at the primary surgery. When placing it, the pins must go through designated safe corridors to avoid hitting neurovascular structures.
Furthermore, the construct has to allow the plastic surgery team enough physical access to the wound to actually perform the soft tissue cover later.
If you plan to convert that external fixator to definitive internal fixation, like an intramedullary nail or plates UK standards mandate, this happens within 72 hours of the primary surgery.
But here is a golden rule you must never break. Internal orthopedic implants should never be placed if immediate soft tissue cover cannot be achieved.
Metal sitting exposed in an open wound is an absolute disaster. It is associated with catastrophic infection rates.
That brings us to our final phase, soft tissue cover and segmental bone defects. If we can't close the wound bed immediately, how do we manage it temporarily?
Your temporary options include topical negative pressure dressings, but you have to state that these should not be used for greater than 7 days. Otherwise, you run an increased risk of deep infection.
The alternative is an antibiotic bead pouch.
This is where you take polymethyl methacrylate, or PMMA, cement, impregnated with a heavy dose of antibiotics, usually gentamicin or tobramycin. Place it right into the wound and cover it with a semi-occlusive film.
It delivers massive local concentrations of antibiotics directly to the tissue and stays effective for up to 21 days.
For definitive cover, you need vascularized soft tissue. UK standards dictate this absolutely must be performed by senior specialist teams within 7 days of the injury.
If you delay past 7 days, you significantly increase the likelihood of encountering friable, fibrotic recipient vessels, which completely compromises your microsurgical anastomosis.
When it comes to flap selection, let's break down local flaps versus free tissue transfer. Local or regional fasciocutaneous and muscle flaps are strictly reserved for low-energy injuries where the zone of trauma is very limited.
For the proximal third of the lower leg and knee, your workhorse is the pedicled medial gastrocnemius. For the middle third, you're looking at the medial hemisoleus or the bipedicled tibialis anterior.
But for high-energy open tibial fractures, free tissue transfer is the absolute mainstay of treatment, and you need to be prepared to discuss the ongoing debate between fasciocutaneous and muscle flaps.
Proponents of fasciocutaneous flaps argue they are aesthetically superior, they provide minimal donor site morbidity, and they are much easier to re-elevate later if you need secondary access for bony reconstruction.
On the other side, proponents of muscle flaps argue that muscle conforms far better to complex, irregular dead space cavities. Plus, they act as muscle macrophages, bringing a robust blood supply that reduces the likelihood of infection and drastically improves bone healing.
When you're hooking up these free flaps, your recipient vessels in the lower leg are typically the anterior tibial artery or the posterior tibial artery.
If you use the posterior tibial, it can be approached medially between the flexor digitorum longus and soleus. Or you can approach it posteriorly via the Godina split.
The Godina split involves making a posterior midcalf incision, deepening it right between the heads of the gastrocnemius, and going directly through the soleus to access the vessels. Finally, how do we reconstruct large segmental bone defects?
If the defect is small, less than 5 centimeters, you can manage it by primary bone shortening. But acute shortening of greater than 5 centimeters is incredibly dangerous.
It kinks the local vessels, resulting in distal ischemia, and causes circumferential full-thickness necrosis of a donut-shaped block of adjacent soft tissue.
For larger defects, we use the temporary placement of an antibiotic-impregnated PMMA spacer to maintain the limb length. This is the masculette technique.
It relies on the induced membrane that forms around that cement spacer. At a delayed second stage, usually around 6 weeks after the soft tissues have completely healed, you open it up, remove the cement, and fill that highly vascularized membrane cavity with morselized cancellous bone graft.
Alternatively, you can use circular frames like the Ilizarov or Taylor spatial frame for bone distraction or bone transport.
The bone is essentially lengthened by turning special screws on the external frame, stretching the callus at a rate of 1 millimeter per day.
Lastly, you can reconstruct with vascularized bone grafts. The most common are the free fibula or the deep circumflex iliac artery or DCIA flap.
But you must note to the examiner that it takes upwards of 18 months or more for this transferred bone to undergo strengthening and hypertrophy. Allowing full weight bearing during this early period carries a massive risk of fracturing your newly transferred graft.
It's a very long road to recovery.
To successfully salvage these limbs and to master these boards, you need a flawless command of these protocols. From the 3 E's and the 4 C's to the strict timelines of revascularization and flap coverage, every single detail matters.
Here is a final thought for you to ponder as you synthesize all this material.
Mm.
We discussed utilizing newer ICG fluorescence technologies to determine skin viability during that initial debridement. As real-time metabolic imaging technologies become increasingly portable, precise, and advanced, how might that completely eliminate the need for the traditional and frankly often tissue-damaging second-look debridement in the near future?
That is a brilliant point and definitely something to think about as the field evolves. I want you to leave a comment or a question about today's deep dive wherever you are listening right now. Keep studying hard, trust the protocols, and we will see you next time.